Welcome, everyone. We'll give a minute for people to join. Right, it's 13:01. I think we should begin. So welcome. Welcome to everyone. Good morning, good afternoon, good evening, and a special welcome to those of you who are living far away, where it's late at night or very early in the morning. We really appreciate your being here. We welcome you today to the WHO EPI-WIN webinar on the WHO guidelines on meningitis diagnosis, treatment, and care, a new tool for outbreak preparedness and response. This is a huge milestone because this is the first time WHO has brought out such a guideline on meningitis. And you have today a very exciting team that will be introducing this guideline and what it means to you. We're fortunate to have with us Dr. Maria van Kerkhoff, Director for EPM in WHO, who will provide the opening remarks. Then Dr. Lorenzo Pezzoli, who's the team lead in this area, will give you an overview of the guidelines and what it means, followed by Dr. Nicolo Binoli, who will explain at length the details of the recommendations and their applicability in emergency settings in particular. But what does it mean? How can you use it, especially at the country level and in emergency settings? For that, we have two experts, Dr. Joseph Oliver Comey from the Ghana Health Services and Dr. Daniela Garon from Medicine Sans Frontières. As usual, we have the regular announcement. This webinar is being recorded, and the recording will be shared on our website and also with all those who registered. This is, as usual, we'd love to hear from you. So please introduce yourself in the chat. If you have any comments, insights, experiences you want to share, we'd love to hear from you. Please put it on the chat. But if you have questions, please put it in the Q&A box today. And that's how we can keep track of it. And we will try to respond to as many of your questions as possible. So without further ado, I'd like to invite Dr. Maria van Kerkhoff for the opening remarks. Thank you.
Thanks so much, Supriya, and good morning, good evening, everyone. Thanks so much for joining this webinar. It's really a pleasure to give some brief opening remarks, which presents an overview of the first ever comprehensive WHO guidelines on meningitis diagnosis, treatment, and care, and discusses how they can serve as a tool for countries as part of their outbreak preparedness and response efforts. Meningitis does not refer to a single disease, but rather a range of life-threatening infectious threats that continue to extract an alarming toll on populations worldwide. Settings with limited resources and those experiencing recurrent epidemics are most affected, including but not limited to the African meningitis belt region. At the launch of these guidelines a few weeks ago, I emphasized on behalf of the Health Emergencies Program, our Executive Director and the Deputy Director General, Dr. Mike Ryan, that the elimination of bacterial meningitis epidemics is within reach, but only through concerted action by key stakeholders and partners. Developed as part of the Defeating Meningitis by 2030 Global Roadmap, these guidelines represent the culmination of dedicated, multidisciplinary efforts across WHO and its partners to combat one of the most complex and devastating public health threats globally. At the 78th World Health Assembly, which just concluded yesterday, member states placed strong emphasis on the importance of defeating meningitis. Countries from all WHO regions voiced their support for the global roadmap, reported progress, and called for further investment in surveillance, clinical care, vaccination, and laboratory systems. This broad momentum signals a renewal of political will and global solidarity in the fight to end meningitis epidemics. In 2021, the global burden of premature mortality and disability due to meningitis was estimated to exceed 15 million disability-adjusted life years, highlighting the urgent need for improved control strategies. In addition, meningitis often has a devastating social impact on affected individuals and imposes a significant financial burden on their families and communities. Clinical management of people with meningitis is a complex task for every frontline healthcare worker, and it can be particularly challenging in outbreak settings or during humanitarian emergencies. These guidelines represent a fundamental milestone in our global meningitis response. With over 35 evidence-based recommendations, they offer comprehensive guidance on meningitis diagnosis, antibiotic therapy, adjunctive treatment, supportive care, and the management of sequelae. During meningitis epidemics, timely and accurate diagnosis, along with prompt and appropriate management of affected individuals, is the very first step of the emergency response and remains the cornerstone of outbreak control. Moreover, early detection and confirmation of cases is critical to initiating the broader public health response to an epidemic. For example, in the context of the meningococcal disease outbreak, identifying and characterizing the causative pathogen through sample collection and laboratory testing is essential to launching the timely and effective reactive vaccination campaign and informing post-exposure prophylaxis strategies. The development of these guidelines was truly a collaborative endeavor, and I wish to extend my deep appreciation to all of our partners, our expert groups, all of the WHO departments and units across headquarters, regional, and our country offices that were involved in the guideline development, and a special thanks to my team who's on the call here today. It is our collective responsibility to ensure that these guidelines are implemented where they are most needed in all hospitals, in all healthcare facilities, including in emergency settings. Their dissemination and implementation will be critical to reduce the burden of meningitis and saving lives around the world. Thank you so much for joining this webinar today. Thanks to all of our speakers who've taken the time to explain this, and I'm looking forward to hearing more in the Q&A. Over to you. I'm not sure if I hand back to Supriya or if I hand over to you, Lorenzo.
Maybe it's back to me. It's directly to me.
There you go. Hand over, there you go.
Thanks a lot, Maria. And following up from Maria's introduction, I will just give a brief overview of how these guidelines insert themselves into a broader defeating meningitis strategy. And many of the things have been already said by Maria in the excellent opening. Let me share the screens. Apologies, I was waiting for. Let me share the screen. Voila. When we switch too much between Teams and Zoom. Great. Can you see the screen? And indeed, these guidelines are a critical tool in outbreak preparedness and response. And I want to give a brief overview of how they insert themselves into the broader meningitis, defeating meningitis strategy. We work in the emergency program, and I think there's nothing scarier than meningitis when it comes to an infectious disease. It is truly a global and deadly threat. It can strike anyone and anywhere in the world, and it is caused by many pathogens, with bacterial meningitis being the most deadly. We estimate that every year, 25 million cases of all-cause meningitis occur, with 1.6 million cases being bacterial meningitis. Acute bacterial meningitis often starts with generic symptoms. This is what makes it very scary. And then it strikes fast and hard. Within 24 hours, 1 in 6 people can die, and 1 in 5 can end up with long-term sequelae. The highest burden is in young children and in the area of Africa called the meningitis belt. And this is a disease that has a heavy toll on families, especially in low resource settings, because of the high case fatality rate and the long-term sequelae it causes. What is it from a clinical point of view? It is an infection, an inflammation of the tissues surrounding the brain and spinal cord, which are the meninges. And it can be divided into acute meningitis, which is a global infectious disease meningitis. A lot of it is viral, but then there is acute bacterial meningitis. And acute bacterial meningitis can also cause sepsis and septic shock if these bacteria go to our bloodstream, causing a disseminated infection. The prognosis for acute bacterial meningitis is not good. It has a high case fatality rate and a high risk of sequelae, as we have seen. It is more favorable if we have viral meningitis with a very low fatality rate and very low risk of sequelae. It can cause sequelae and complications in 1 in 5 patients, starting from hearing loss, cognitive impairment, intellectual disability, epilepsy. Apologies, these slides are moving on their own. Epilepsy, motor deficit, hydrocephalus, limb or digit loss, and with the vision of defeating meningitis by 2030, WHO and partners have launched the Defeating Meningitis Roadmap, which aims to achieve a world free of meningitis, eliminate bacterial meningitis epidemics, reduce cases by 50% and deaths by 70% from vaccine-preventable bacterial meningitis, and reduce the disability and improve quality of life after meningitis due to any cause. It is implemented, this roadmap is implemented through WHO Meningitis Technical Task Force, which is a global group of global experts. Many of them have contributed to the guidelines we're discussing today. Many of them are talking today and surely participating. This group ensures technical coherence, country relevance, and unified actions. And it focuses on 4 bacterial meningitis pathogens. For us in the emergency programs, the first 2, Neisseria meningitis and Streptococcus pneumoniae, are really the focus of our work, because these are the ones who are outbreak prone. I would include also Haemophilus influenza, but thanks to a very good vaccination coverage, we don't see outbreaks of Haemophilus influenza anymore. Unfortunately, we do still see far too many outbreaks of Neisseria meningitis and Streptococcus pneumoniae. And this is a truly, as Maria already said, a truly cross-divisional collaboration between the Brain Health Unit in WHO, which leads on clinical care of neurological sequelae and long-term care, the Immunization and Vaccine Department, leading on immunization and vaccine strategy, and ourselves, WHE, in the Epidemic and Pandemic Management Department, leading on outbreak preparedness and response. And it is articulated into 5 interconnected pillars. One of the pillars is indeed diagnosis and treatment, and these guidelines insert themselves into this pillar, but they are, of course, their implications go beyond the diagnosis and treatment pillar and towards in all the five interconnected pillars, because correctly identifying patients is only the starting point of the Defeating Meningitis Global Roadmap. Every epidemic indeed starts in the community with somebody falling ill. But what happens next can determine not just their fate, but also the fate of many others in the community, because this is an infectious disease that spreads incredibly fast. So diagnosis and treatment are at the heart of both saving lives and stopping the spread. But they are much more than just clinical tools, these guidelines. They are the foundation to epidemic response, because when we correctly identify the causes of meningitis, we give patients the right treatment, we avoid unnecessary or ineffective antibiotics, but we also trigger the right public health response. We guide vaccination use because, of course, to conduct reactive vaccination campaign, we need to know which pathogens we are seeing. So identifying the pathogen and correctly diagnosing it, and also identifying the serogroup and the serotype are key to plan our interventions. And so the way forward is now that collectively with countries and partners and the civil society, we support the dissemination of these guidelines. We train healthcare workers in the applications. We support countries in integrating them into national strategies. And we can only do that with the support of all of you. We will hear today some of our partners in Ghana who has already started using this guidance in the field. And I'm looking forward to those discussions. And I thank you very much. I think that only together we can defeat meningitis.
Thank you very much
for the slide changing automatically.
Sometimes these things happen, technology things, but thank you so much, Lorenzo, for providing that overview of the WHO guidelines. And now, my apologies also to everyone. I had a slight tech issue today and got frozen earlier, but thank you, Lorenzo, for please continuing. But now I think it's time to hear from our audience before we go on to the next speaker. So please go to, we have a short quiz for you. Please go to, can you see my slide? Slido.com, hashtag 2554322. Slido.com, hashtag 2554322. And please, yes, I think today we seem to have a tech. That's not right. So my apologies for this. I'm not sure why we are having a tech issue today. So please, I think it should be working now. Can you see the slide? So the question is, which of the following is the most accurate statement regarding the response to a meningitis outbreak? We have 5 options here, and we'd love to hear from you. And the answer is D. So thank you very much. And I will stop sharing. And I'd now like to request Nicolo to tell us more about the guidelines.
Thank you very much, Priya. I hope you can see my screen by now. I'll be giving an overview of the technical content of the guidelines, which are, again, as we said, the first comprehensive WHO clinical guidelines on meningitis. They were published last month, and they're organized into 3 different chapters. Diagnosis first, which focuses on lab investigations and cranial imaging. Treatment, with a special emphasis on acute care. And third, meningitis of sequelae, which covers the long-term physical, neurological, and psychological complications of meningitis. These guidelines are intended for global use and were designed to be implemented in all settings, including resource-limited and emergency context. The guidelines address acute onset community-acquired meningitis in adults, adolescents, and children over 1 month of age. It is important to note that they do not address meningitis in neonates, hospital-acquired meningitis, subacute or chronic meningitis, or non-infectious forms of meningitis. They are primarily intended for healthcare professionals and frontline clinicians, but they're also directed at policymakers working at the national and international levels. And finally, they also aim to serve as a resource for academic institutions, as well as NGOs, to support research, teaching, and capacity building and strengthening activities. The WHO guideline development process involved several stages with contributions from experts across WHO and external groups. After the planning phase, 20 guideline questions were developed using the PICO format, which then informed the systematic reviews.
Nicolo, sorry, are you sharing your slides? Because we don't seem to be able to see them. Yeah, great, thank you.
Yes. So the WHO guideline development process, I was saying, involved several stages with contributions from experts all over the world, across WHO and external groups. After the planning phase, 20 guideline questions were developed using the PICO format. And this informed the systematic reviews that were subsequently carried out. And based on the evidence and following the GRADE approach, the guideline development group formulated the recommendations and good practice statements, which do form the core of the document, which we're going through in a moment. And this is just to reiterate that multiple groups participated in this effort, coordinated by WHO, including the guideline development group, 5 evidence review teams, an external review group, and several WHO teams and units across the organization, bringing together really a rich and diverse combination of technical and normative experience and expertise. But what is the actual content of the guidelines? And so let's start with meningitis diagnosis. First of all, in all individuals with suspected acute meningitis, a lumbar puncture should be performed as soon as possible, preferably before the initiation of antibiotic treatment, unless there are specific contraindications or reasons for deferral. And we do know that examination of the CSF is crucial for differential diagnosis, for pathogen identification, and it also helps therapeutic decisions. A lumbar puncture can be performed safely in most cases, but there are certain conditions that increase the risk of complications. And the procedure should not be done if the patient has a known or suspected bleeding disorder, if there is a skin or soft tissue infection close to the lumbar puncture site, or if they present with hemodynamic or respiratory instability that requires clinical intervention. Additionally, lumbar puncture can increase the risk of brain herniation in patients with increased intracranial pressure, such as those with severe brain swelling or space-occupying lesions with midline shift. And to reduce this risk, it's really important to identify those patients that are at particular risk where lumbar puncture should be deferred. And these include individuals with the Glasgow Coma score less than 10, focal neurological deficits or cranial nerve deficits, papilledema, new onset seizures as far as adults are concerned, and severe immunocompromised state. In all cases, meningitis remains a medical emergency, and any delay in lumbar puncture, including performing a CT scan, by the way, should not contribute to any delay in treatment initiation. Once CSF is collected, macroscopic appearance should be inspected, and a number of initial tests should be performed, including glucose and protein concentration, white blood cell count, total and differential, and ground stain, all strongly recommended by these guidelines. All of these investigations have varying sensitivity and specificity. We're not going to go into the details of that, but none can confirm or rule out a diagnosis of meningitis when taken alone. And therefore, an integrated combined approach to the interpretation of these findings is essential to reduce the risks associated with relying on individual tests, such as false positives and false negatives. And the diagnostic yield of these investigations may decrease if antibiotic treatment is initiated prior to lumbar puncture. Therefore, they should be performed as soon as possible. And finally, a note about the importance at the country level to establish and implement a context-appropriate laboratory testing strategy with clear pathways for sample collection and analysis. In resource-limited settings, these initial investigations should be available in peripheral health facilities, but when they're not, the WHO guidelines do recommend that CSF samples should be collected and properly transported to higher level laboratories. And you can see how the initial CSF findings can really help distinguish bacterial from viral meningitis, which, by the way, are within the scope of these guidelines. For example, classic CSF features of acute bacterial meningitis include a cloudy appearance, elevated white blood cell count with neutrophil predominance, low glucose concentration, and very high protein levels. The guidelines also emphasize that culture of CSF specimens is and remains the gold standard for diagnosing bacterial meningitis and should always be associated with antimicrobial susceptibility testing. CSF collection should ideally be done as soon as possible because the diagnostic yield of culture decreases if the sample is collected after antibiotic treatment is initiated. And finally, and very importantly, culture and AST results should be used to tailor antibiotic therapy based on identified pathogens and drug resistance profiles. These often means that we need to replace a broad spectrum antibiotic like ceftriaxone, for example, with a narrower spectrum antibiotic proven to be effective against that particular strain. Such appropriate use of antibiotics does play a key role in reducing the overall risk of antimicrobial resistance. So we also need to be cognizant of the public health impact of individual clinical actions. Next up, the guidelines also recommend performing molecular testing, specifically PCR on CSF specimens from all suspected cases. However, because of the risk of false positives, PCR results, this is very important, should be interpreted in the broader context of the clinical presentation and lab findings. And importantly, and this is a very key point, PCR is not meant to, in any way, shape, or form, routinely replace culture and antimicrobial susceptibility testing, which do remain the gold standard for pathogen identification and characterization of drug resistance profiles. Blood tests. There's also a section on blood tests, which can be a valuable tool to support or confirm diagnosis of meningitis, especially when a lumbar puncture cannot be performed. Specifically, blood culture serves as a confirmatory test, and in all individuals with suspected meningitis, it should be performed as soon as possible, again, preferably before the initiation of antibiotic therapy. And similar to CSF, blood culture and AST results should be used once again, to tailor antibiotic therapy based on the isolated pathogen and drug resistance profiles. Then in individuals with suspected meningitis, there's a subset of tests that can be considered, that should be considered when the resources allow, and these include white blood cell, peripheral total count, and differential count, C-reactive protein, or procalcitonin. Once again, none of these tests can be used to confirm or exclude bacterial meningitis when taken alone. They should never be used in isolation, and the results must be interpreted again in the broader context of the clinical presentation and CSF findings. Glucose, why glucose? Because we need to calculate immediately before lumbar puncture serum glucose levels to calculate CSF blood glucose ratio. Also, disease-specific serology can be useful when certain bacterial or viral conditions are suspected, including HIV, by the way. And finally, just a couple of words on malaria in malaria endemic areas. In malaria endemic areas, cerebral malaria can actually present with the same symptoms as acute meningitis. And all suspected cases of malaria should have a parasitological test, either microscopy or an RDT, to confirm the diagnosis. In malaria endemic areas, therefore, A positive malaria test confirms malaria infection, requires anti-malaria treatment. We all know that, but it does not rule out the possibility of concurrent meningitis. And you can see this from this flowchart, by the way. At the same time, a negative malaria test should further corroborate the clinical suspicion of meningitis. There's a section on in the guidelines about cranial imaging. And what about cranial imaging? So first of all, in individuals with meningitis, the risk of brain herniation increases in the presence of cerebral edema, severe cerebral edema, or space-occupying lesions with midline shift. These conditions can only be detected through cranial imaging, such as CT scan. Therefore, cranial imaging should be performed, but not performed routinely in all suspected cases of meningitis. Rather, it should be performed exactly in those individuals that are a higher risk of brain herniation to identify and rule out space-occupying lesions with midline shift. And who are those patients? These are exactly the same patients that present with any of the listed factors for lumbar puncture deferral that we had discussed before. Now, how does this recommendation translate into practice? If cranial imaging is readily available and accessible, it should be performed prior to lumbar puncture. Conversely, as you can see from here, in resource-limited settings where cranial imaging is not readily accessible, even through referral, clinicians should defer lumbar puncture until the reasons for deferral have fully resolved. So that's what the recommendations indicate. And that pretty much covers diagnosis. And now let's move on to treatment and acute care. Acute meningitis is a medical emergency that requires prompt diagnosis and urgent care. We all know this. So therefore, all suspected cases should be immediately admitted to or urgently transferred to an appropriate healthcare facility for further management. How did WHO define an appropriate healthcare facility? Well, it's defined as one facility where lumbar puncture can be performed in the absence of contraindications and adequate management of severe illness can be ensured. It can be a hospital. In some cases, it can also be an appropriately equipped health center. Now, as part of the patient's acute management, there are three cornerstones: antibiotic therapy, adjunctive steroids, and supportive care. And we're going to go through all of these in a little bit of detail. Considering that meningitis is a medical emergency, IV empiric antibiotic therapy is required, is recommended. But when should antibiotic treatment start? The simple answer is as early as possible, and ideally within 1 hour of a hospital admission. As mentioned earlier, any delay in diagnostic investigations should never, ever delay the start of treatment. And you can see this from this simplified algorithm. For a suspected case of meningitis in an appropriately equipped healthcare facility, you perform lumbar puncture, you collect blood samples, and you start your antibiotic therapy as soon as possible, again, within 1 hour of admission, if possible. But what about those patients that are admitted to healthcare facilities that are not equipped for lumbar puncture performance or adequate management of severe illness? This may be the case of a rural health center in a low-income country, for example. And this is often the case in emergency settings. And these patients should be referred, obviously, to an appropriate healthcare facility as soon as possible, and especially when a clinical significant delay in transfer is expected, pre-referral antibiotics should be considered. What does it mean? It means that empiric antibiotic treatment is given before transfer to an appropriate healthcare facility, simply because it may be beneficial when acute bacterial meningitis is considered and a clinically significant delay is most likely. In these situations, both IV and IM administration of antibiotics are acceptable. IM, especially if an IV line cannot be secured. This approach, known as pre-referral therapy, is similar to what's used in severe malaria and was designed to specifically address operational and feasibility challenges in resource-limited settings, in emergency settings where referral systems may be suboptimal. When it comes to antibiotic regimens, IV ceftriaxone or cefotaxime should form the backbone of therapy. And if there are risk factors for listeria, elderly patients, pregnant women, immunocompromised hosts, then IV ampicillin or amoxicillin should be added to the initial regimen. And finally, in areas with high prevalence of penicillin or third-generation cephalosporin resistance, of strep pneumo, IV vancomycin should be considered in addition to the initial regimen. Very importantly, this is extremely important, antibiotic regimens should always be reviewed and adjusted based on culture and AST results, and they should be reviewed and optimized accordingly. The goal here is to minimize inappropriate use of broad-spectrum antibiotics and the emergence of drug-resistant pathogens, which means basically in clinical practice, narrowing the spectrum when possible and stopping any antibiotics that are no longer needed. Now, in terms of how long to treat, the duration partially depends on the specific pathogen, and the table shows the various regimens for the most common pathogens here. We're not going to go through details of this, but all of the information is included in the guidelines. What happens, however, when the pathogen is not identified and remains unknown? Well, in non-outbreak settings in individuals with suspected meningitis or probable meningitis, stopping antibiotics after 7 days of treatment, provided the person has fully recovered, is recommended. This is a huge change in clinical practice when it comes to non-epidemic settings. And what about outbreaks? How does treatment differ from non-epidemic settings? Well, during meningococcal or pneumococcal disease epidemics, IV ceftriaxone is preferred over cefotaxime because it's more widely available, has a longer half-life, and it should be given at maximum dosage every 12 hours in an inpatient setting. In meningococcal disease epidemics, suspected and probable cases should receive 5 days of treatment, whereas during pneumococcal disease epidemics, the recommended duration is longer, 10 days, although this is a conditional recommendation based on limited evidence. And the flowchart here helps visualize it all at a glance, whereby you have ceftriaxone monotherapy for 5 days during meningococcal meningitis epidemics and 10 days during pneumococcal meningitis epidemics. The guidelines also address potential operational challenges that may occur during outbreaks, which is particularly relevant to this meeting. First, when completing antibiotic therapy in an inpatient setting is not feasible, if the person is clinically stable and able to return to the healthcare facility every day, they can be discharged and continue treatment with full dose of ceftriaxone once daily in an outpatient setting. Second, in large-scale meningococcal disease outbreaks, where health services may be stretched to capacity and a full 5-day course may not be feasible, then single-dose treatment protocols can be implemented, provided there's lab confirmation that the outbreak is due to Neisseria meningitidis, and the person can be reviewed after 24 and 48 hours. Finally, during epidemics, antibiotic treatment should be provided free of charge. This is a typical WHO recommendation through government health services. That covered antibiotic therapy. Now, what about adjunctive and supportive care? Guidelines also address these aspects, and let's go through those very briefly. In selected settings, adjunctive steroids can be given to individuals with acute bacterial meningitis in addition to antibiotics, with the rationale of reducing the risk of death and neurological complications. This is the rationale why we're using corticosteroids in some settings. Let's start from non-epidemic settings and their use outside outbreaks, where, well, when lumbar puncture can be performed, IV steroids should be started alongside the first doses of antibiotics. Where lumbar puncture cannot be performed for whatever reason, steroids may still be given, provided that bacterial meningitis is still strongly suspected from a clinical standpoint and no concurrent condition contraindicates their use. Again, dexamethasone here is the steroid of choice. When it cannot be administered for whatever reason, hydrocortisone or methylprednisolone can be used instead at equivalent dosages. During outbreaks, the situation changes completely. During meningococcal disease epidemics, IV steroids should not be routinely used in suspected or probable meningococcal meningitis cases due to the lack of evidence regarding suggesting a beneficial effect of steroids in individuals with confirmed meningococcal meningitis, especially in terms of mortality and other neurological outcomes. By contrast, during pneumococcal disease epidemics, steroids should be started with the first dose of antibiotics in all suspected and probable cases of a pneumococcal meningitis. And here you have it in a flowchart where you can clearly see the different approach between meningococcal and pneumococcal disease epidemics. Of note, these recommendations apply only if the causative agent, only if the causative agent, sorry, I'm hearing background noise, is being confirmed by culture or PCR. There are recommendations on osmotic therapy, which is not routinely recommended. I'm hearing background noise. I'm sorry, but can someone mute whoever is talking? Thank you. There are also recommendations on fluid management, and the guidelines provide a conditional recommendation against fluid restriction, which was used to be used in children in some settings. For maintenance fluids, the preferred route of administration is oral or by enteric tube, like a nasogastric tube. And if fluids cannot be given orally or by enteric tube, isotonic solutions should be routinely used as maintenance fluids, Ringer's lactate or normal saline. There are some recommendations on seizures, which should be managed depending on several factors, including the clinical stability of the patient, the risk of having recurrent seizures. There's a condition recommendation saying that anti-seizure medicines in people with acute symptomatic seizures from meningitis should be continued for no longer than 3 months, as long as no further seizures occur during that time. Last but not least, sequelae, last chapter of the guidelines, which do strongly recommend assessment and management of sequelae. Specifically, individuals with acute meningitis from any cause should be reviewed for sequelae by a healthcare provider prior to discharge and that follow-up within 4 weeks. Same goes for audiological screening. And also in individuals where one or more sequelae or hearing loss have been detected and diagnosed, rehabilitation services should be provided as soon as possible. Final word on post-exposure prophylaxis. These are the last slides. And this is a very important topic because it's really important for outbreak response. Antibiotic prophylaxis, first of all, is recommended for whom? For close contacts of cases of meningococcal disease, whether or not they present with meningitis, by the way. And the idea and the objective is to prevent secondary cases and decrease asymptomatic nasopharyngeal carriage of meningococcal infection. So we're only talking about one single type of bacterial meningitis, although the most epidemic prone. The choice of antibiotic should be based on antimicrobial resistance patterns, but it's very important to understand who qualifies as a close contact here. And close contacts, the guidelines say, should be defined based on local context and available resources. But the idea is that we're talking about people who are exposed to an index case between 7 days before symptom onset up to 24 hours after initiation of antibiotic treatment. And these include household contacts, as well as all people directly exposed to the patient's oral secretions. When it comes to antibiotic regimens, I was saying the key is using antibiotics proven to eradicate nasopharyngeal carriage of meningococcal bacteria. And the choice of antibiotics should be guided by antimicrobial susceptibility patterns, either prevalent in the community or adjusted as necessary based on results on index cases. Which antibiotics are recommended? Single IM dose of ceftriaxone or single oral dose of ciprofloxacin are the 2 main options, although we're increasingly seeing reports of ciprofloxacin-resistant strains in several parts of the world. If neither of these 2 options can be given, then rifampicin twice daily for 2 days can also be given. And finally, the target population varies in accordance with the epidemiological setting. In the presence of sporadic disease, post-exposure prophylaxis is given to close contacts of lab-confirmed cases, whereas in the context of a large-scale epidemic, close contacts of clinically suspected cases are the target population because lab confirmation can be resource-intensive and sometimes suboptimal. Next steps for outbreak control. Well, WHO is undertaking efforts, first of all, to disseminate these guidelines through ministries of health, national public health bodies, and translating them into the various UN languages. Also, we're revising and updating standard case definitions of bacterial meningitis and meningococcal disease for outbreak investigation and response, a critical tool for outbreak control. And finally, we're developing job aids and clinical tools for healthcare professionals. Actually, the good news is that we already started this. And earlier this year, for example, in coordination with the national, regional, and district health authorities of Ghana, during a pneumococcal disease outbreak, we developed context-specific job aids and clinical tools to strengthen clinical capacity in affected areas. And this is exactly what you have in the slide, a job aid and on-the-job training provided by Dr. Komi, who I'm very glad to see in this room with us. And with this in mind, I thank you very much, and over to you, Supriya. Thank you.
Thank you very much, Nicolo. Thanks for that very comprehensive presentation about the guidelines. Now we will, now you know about the guidelines, what it says, but what does it mean in the countries? For that, I would like to welcome Dr. Joseph Oliver Comey. He's the director of the Ghana Infectious Disease Center, and we'd love to hear his perspective. How was this useful? So, Dr. Oliver Comey, northern Ghana is located in the African meningitis belt and experiences recurrent outbreaks of pneumococcal and meningococcal disease. Based on your experience in the epidemic, especially earlier this year, what is your perspective on the potential impact of these guidelines on meningitis outbreak control efforts in the field? How do we assure their effective implementation? Over to you, Dr. Joseph.
So good morning, good day, good evening to all the panelists and to all those of us listening. So like you rightly said, the 5 regions in the northern region in Ghana are part of the meningitis belt. And usually the season starts towards the end of the year and it peaks in March. However, this year, it peaked earlier than expected. So by January,
Dr. Joseph, we seem to have lost you. I'm sorry, I think we've lost Dr. Joseph. Dr. Joseph, are you still there? Yeah, you're back. Thank you.
Sorry. And then despite the good surveillance, we had some deaths. So we approached WHO HQ, and I must say that Nicolo was very helpful when he joined us. And then we developed some job aids from the guidelines that were yet to be published. And I must say, thank you for giving us the opportunity to develop job aids from the yet to be published guidelines. And I must say, it's important that job aids are actually developed because we have guidelines, all right. Translating the guidelines into action on the ground at various levels when you have outbreaks is very important. So we will see that when we got to the ground, the people knew about meningitis, especially at the lower level, the cadre, they knew about meningitis. They were excited about the new guideline that spoke about the fact that we needed to have early initiation of antibiotics. The key antibiotic here was ceftriaxone. Everybody knows that we need to give the ceftriaxone either by maybe by IV administration. But at the lower level, the people were asking, we are not capable of doing IVs. Can we do IM? Even with the IM, our lower level cadre were used to giving IM for vaccination purposes only. So the volumes that we spoke about regarding IM for ceftriaxone was a little difficult for them. If we didn't have job aids, all we would have said was that go by this method, you start with early ceftriaxone, and we move on to the next phases. So for me, this particular response, even on the ground, they helped us to shape up the type of job aids for the various cadre from primary level to secondary level to tertiary level. These are the things that we spoke about. Then I will say, so that we do not feel that it's just enough to have guidelines, I believe that the WHO, together with the experts, should look at developing these job aids for specific cadre of staff at every level in most countries. I believe for us in Ghana, within a few weeks after implementing these things, we realized that our numbers started coming down. Mortalities more or less disappeared. Now we can say that we are over that period. and we didn't see so much problems as in the beginning. We want to implement these things in the last quarter of this year, and we will see better results, I'm sure, in the coming year. So let's keep this point open. I think that we need to develop job aids, and the job aids from these guidelines will help us better respond to pandemics in the resource poor settings. I think these are the few words I want to share with you.
Thank you very much. And it's wonderful to know how you use the job aids in Ghana. And I'm sure many other countries will also be inspired by what you've done. And that is what this webinar is for, to share experiences so that all countries can benefit. So thank you very much. We're really privileged to have you here, Dr. Joseph Oliver Comey, who's the director for the Ghana Infectious Disease Center. Thank you very much. Well, our next question is, and for all the audience, if you have questions for Dr. Joseph, please put it in the Q&A, and we'll do our best to respond either today or maybe in future through writing an email or something if it's not possible today. But now we go to our next panelist, also a very eminent person, Dr. Daniela Garo, who's the International Medical Coordinator for MSF. So Dr. Garon, based on your experience with MSF and as a member of the ICG, how do you see the WHO meningitis guidelines influencing operational decision-making in emergency settings? In particular, what are the key considerations that ensure prompt diagnosis and adequate treatment of the individuals who are affected, both during and outside outbreaks?
Thank you. Thank you, Supriya. Can you hear me well? Can you hear me well?
I can hear you clearly.
Okay. Thank you. Thank you very much for having the opportunity to be in the panel. So we heard from Lorenzo before that we do have a defeating meningitis by 2030 global roadmap to eliminate bacterial meningitis epidemics, reduce the impact of the disease, and improve quality of life after meningitis. However, despite the promises, the promising progresses during the last years, meningitis epidemics remained a severe medical emergency for more than 2.5 million people who suffer the reality yearly, with 1 in 6 that's dying of the disease. MSF teams witness firsthand that the gaps in diagnosis and treating meningitis are far worse in the fragile and complex humanitarian context where our teams work across the globe. Meningitis outbreaks do not happen in a vacuum. Populations affected are usually suffering from multiple other conditions like malnutrition and overlapping risk, including multiple other diseases like measles, diphtheria, cholera, NTDs, among others. MSF welcomed the paramount work on these guidelines on meningitis diagnostic, treatment, and care, because the guidelines represent a unique opportunity to advance timely diagnosis and treatment of meningitis as the base to reduce the impact of the disease at individual as well as at community level. But however, despite the progress made in the recent years in diagnosis, including the increasing number of suspected meningitis cases who had a lumbar puncture, ultimately having better diagnosis require health systems capacity that are closer to facilities where patients are cared for, as well as adequate transport systems to central laboratory and faster turnaround for confirmation of cases. We highly appreciate that the new guidelines are being clear on when to use antibiotic treatment and when the antibiotic treatment should not be withheld if the lumbar puncture is delayed or not possible. We know that most of the clinicians are the fear of the clinicians is one of the common reasons why patients are not getting lumbar puncture. So these guidelines represent a clear recommendations that could help clinicians in their decision making. Suspected meningitis is a medical emergency and need quick and empiric antibiotics. Of course, in high resource settings, antibiotics are often stopped once the cultures are negative, but in low resource settings like where MSF is working, laboratory results are often not available for weeks. So some patients are potentially receiving several days of broad antibiotics that they do not need. If we could have better diagnosis or more available resources for timing diagnosis and referral, we could stop the use of antibiotics that are not necessary. But we are progressing, but we are not yet there. I like what Lorenzo says, that every epidemic starts with a patient, and that is absolutely right. Meningitis outbreaks remain a significant global health concern, with surge cases in the recent years and the expansion of the meningitis belt countries. Timing diagnosis and treatment are at the heart of both saving life and reducing the impact of the disease and stopping the spread. Based on our MSF experience in supporting outbreaks, meningitis outbreaks, and my experience as ICG member when we need to revise the reactive vaccinations request, case identification, diagnosis, and confirmation of outbreaks remains the main delay in a timing response, including a reactive campaign that could prevent further expansion of the outbreaks. We believe the new guidelines represent a milestone to support programs with clear recommendations. With the approval of MEN5 vaccines, we are now in a unique situation where the same tool could be used for prevention as well as response, providing an opportunity to link the two programs, and I think more effectively and save more life. I think this is a unique opportunity we need to explore in bridging the two programs. However, there is an urgent need to increase the production of MEN5, as well as other vaccines like pneumococcal, and focusing on those most at risk. Finally, the new guidelines, along with MEN5, are critical tools in the right direction toward defeating meningitis. Now, more than ever, there is an urgent need to maintain the global commitment with the defeating meningitis roadmap. I think I will stop here, and I thank you for being in this panel.
Thank you very much, Dr. Daniela Garon. That was a very useful insight, especially on how these guidelines can be used with vaccination, with others. We now go to the Q&A section of the webinar, although I'm very conscious we're close to ending time, but we would like to take a few questions from all our panelists, and I can see there's been a lot of appreciation about the guidelines in the chat and also with the Q&A, and it's clearly a tool that's much needed. So the first question, I'm going in chronological order here for the questions, is from Adnan Ahmed. He wants to know about diagnosis and the role of the rehabilitation team if meningitis affects lips or in a speech disability. And he has a second question about, in the lab, what can we check about the intensity and also diagnostic tool to check the treatment outcome? Who would like to take this question? Lorenzo, Nicolo, or even Daniela? Nicolo?
Yes, I'm happy to take the laboratory part on diagnosis. I think that the guidelines recommend a number of CSF and blood investigations to perform or to obtain a meningitis diagnosis and confirmation of the causative pathogen, but there are no lab investigations that are recommended to define or cure. Therefore, what is really important when it comes to clinical practice is the clinical improvement of the patient upon initiation of antimicrobial treatment, and this is defined as resolution of fever or improvement of other symptoms that the patient initially presented with. This is also specified in the guideline document, by the way. Over. Thank you.
Thank you. So, it would
Maybe-
Lorenzo like to add?
Yeah.
Daniela, go ahead.
Yeah, I think because we are not going to have a lot of time. I think all the guidelines need to be accompanying their implementation. I think it's very important that many of these decisions, especially in areas where the diagnostic or the follow-up resources are limited, there is a need to understand the guidelines and the care of the patients from the perspective of the clinicians. They are in front of the patient. They are treating with ceftriaxone. Ceftriaxone is also part of the ICC reactive vaccination because we believe that sending the vaccine for control of an outbreak and at the same time being able to give a ceftriaxone could reduce morbid mortality related to meningitis, but still you need to accompany the clinicians in their decision making and in the situation in the different contexts. So I think it's very important to continue the great work of the Ghana, the SOPs, the different tools needed to understand how to contextualize the guidelines in the different places of meningitis.
Thank you very much, Dr. Daniela. Very important how to contextualize the guideline depending on where they're being used. Would Lorenzo and Dr. Joseph like to add anything to that? Or I can
Just
go
to
to
add, indeed, the guidelines is a bulky document. It contains everything you need to know for meningitis diagnosis and treatment, but now it's the work that we have to do all together with the countries, with the partners, to develop these job aids and to translate them to something that can be easily adopted by a clinician who's facing a medical emergency and probably hasn't time to go through all these documents. So this work that we plan to do is going to be extremely crucial, and I appreciate a lot what Dr. Comey told us, because we did it in Ghana. We also did it in Nigeria, by the way, and now we have to go to all the countries, not only the meningitis belt, but wherever meningitis is still a global health problem. And we will need resources, and this is probably a sore point in the global context, but of course guidelines don't implement themselves alone. We need energies and resources. Hopefully you have the assurance of our team that we will continue working with countries and partners to ensure that we have the tools that we need.
Thank you, Lorenzo, for that assurance. I can see Dr. Joseph as well. Would you like to add something, on the lab issue and the context, how important that is? You have the guidelines.
So for me, I work in a resource poor setting. So I go by a lot of the clinical response of the patient. So once I've started my ceftriaxone and my patient has improved over time, most of the time you will not have us do another lumbar puncture to make sure that we have cleared the organism from the system. Once the patient is fine and patient is up and doing in the resource poor setting, this is how we will do it. That's why I keep on stressing on the job aids. I'm happy Lorenzo says we're going to go forward. Yes, we know that in this time when there is no money, but I guess that when we put our acts together, our resources together, we can make this a reality in most resource poor settings. And this, I'm sure, will be the game changer when it comes to dealing with the outbreaks of meningitis in the belt. Thank you very much.
Thank you very much. I know we're over time, but there are quite a few questions. So the next question is by Vishal Gupta, who also talked about in the LMIC setting, especially in rural hospitals. And I think you may have addressed this, but what is WHO's vision on rapid diagnostic test implementation in peripheral settings from CSF sample? Rapid testing like ICT based on local epidemiology, like Neisseria meningitis, strep pneumonia, and grip B strepto. So excuse me because I am not at all from this field. I hope I've got that correct. But would any of you like to comment on that? I think you've sort of
I can start very
explained everything.
briefly. I think this is
Yeah.
a crucial question. And of course, we're talking of meningitis, multiple causes. So multiple causes, multiple tests, it's a very complex field. I guess for us, one priority is Neisseria meningitidis, meningococcus, and we're working with the partners to develop better rapid diagnostic tests that can be used at bedside to identify the agents, meningococcus, and the serogroup. This is extremely important to guide vaccination, reactive vaccination campaigns. So we have, together with our partners, developed a TPP, a target product profile, which is basically a list of how a diagnostic test should look like, what type of performance it should have to be effective. And now we are assessing some manufacturers who would like to produce this rapid diagnostic test, but it is obviously a long process and we are not there yet. It is slightly easier to diagnose, for example, Streptococcus pneumoniae, especially if there's a presentation in that is not only meningitis, but it is pneumonia, because for that we have rapid diagnostic tests that can be used on urines. Because the big limitation, no matter what the test you use for meningitis, is the collection of the cerebrospinal fluid. So you need a lumbar puncture, as Nicolo showed, to really diagnose meningitis in the most accurate way. I don't know, Nicolo or any other panels. Maybe also Joseph talking about the challenges in the field, if you want to complement.
Nicolo, would you like to add something? You're muted.
I can add also a small technical note regarding rapid diagnostic tests within the guidelines. So the guidelines do not talk about rapid diagnostic tests because at this point in time, there are no rapid diagnostic tests can be reliably used for clinical practice, although there are some that can be used for surveillance purposes and for outbreak detection purposes as well. I just wanted to clarify this because I haven't touched upon this topic in my presentation. Thank you.
Thank you. And Dr. Joseph, do you want to add anything from the CANA perspective?
Well, sorry, I guess that for us, the challenge or what we did mainly was we educated most of the people, and then for me, the key thing was the rapid initiation of antibiotics for suspected cases. I must say for Ghana, it was a little easier for us in the sense that during the meningitis period, the government decided that everybody who was being managed for meningitis was managed free during that period. And Nicolo can attest to it that it was free during that period. So a lot of people also presented early, and that also helped maybe in quickly dealing with the problem. Thank you very much.
Thank you. And Daniela, would you have anything to say to that? You don't have to, but I'm just wondering.
No, I think I wanted to re-emphasize it's the clinician in front of the patient. I think this is very important. There are all these dimensions between the relation, the space of this clinician trying to save the patient with limited situation, to the discussions on meningitis that happen on all different levels. So I think the new guideline is helping clinicians in that moment to manage an emergency, and is giving the space to accommodate situations where resources exist or not exist or are delayed. So I really wanted to take this as my last message. And of course, countries will help on the shop aids. Many exist already. Many of the situations exist. How to manage fever, unknown fever in resource limited setting, in endemic countries, in countries with other diseases that also can create meningitis. Is an integrated approach from a patient's perspective, and that's what clinicians are needing the most. And I think that's my message.
Thank you very much. We have many other questions, including one on, why is the focus on bacteria rather than virology? But in the interest of time, we've gone already 11 minutes over. And so I think we should, if it's okay with you, stop here today, unless the panelists would like to continue with the questions. I leave it to you.
We can stay on a bit,
Okay.
but
Yeah. Right. Maybe one more question.
Okay.
If
And also,
that's
there's
okay.
been a lot of questions about if the presentations will be shared and.
Yes. So for that, all presentations will be shared if the speakers agree. And I can see the speakers nodding. So yes, the presentations will be shared. So will the recording. And that's also been put on the chat of this webinar. It will be shared with all registrants, and we encourage you to please also share with your networks, because clearly this is of interest and will be useful to many people. And it's also going to be on YouTube, and we will share the link with that. So please do share widely to whoever may be interested and will find this useful. So to come back to the question, then shall I go to the question on by Nesrin Ben Salem, who says, my concern is the fact we're still focusing on bacterial etiology and underdiagnosing, undertreating viral etiology, which have its own part in the various sequelae and fatality. According to some papers, in both adults and a pediatric population, viral is from 30 to 40%, which is still huge. What do you think? And any new ecology updates worldwide to share from experts? So over to
Maybe
you.
I would start
Go ahead.
to mention that this is the value of increasing access to lumbar puncture, because it's very, from a clinical perspective, it's very difficult to differentiate. So if you don't have the possibility to rule out bacterial meningitis, then you will treat it with antibiotics and might be 30–40% viral. So whenever it's possible to access lumbar puncture and to support clinicians on being confident to perform a lumbar puncture with a timing referral of the sample for a proper investigation, that will be the ideal situation in which you will stop antibiotics. Otherwise, at the moment, the delays in having a sampled transportation, diagnosis, and coming back a turnaround of result, you end up your antibiotic treatment. So I think that lumbar puncture is a critical step here. Advancing will be, for me, critical.
I can also take that question on following up on what Daniela just said, in that, first of all, the guidelines include viral meningitis. They address acute onset community-acquired meningitis. And all of the tests that we discussed, the CSF investigations that we discussed, protein, glucose, white blood cell count, and even PCR can be used to help the differential diagnosis between bacterial meningitis and viral meningitis, and PCR also can be used to isolate and identify viral pathogens. This is, obviously a very important topic that should not be neglected. Then the attention of the guidelines also focuses on antibiotics, which, by the way, are recommended whether the patient has bacterial or viral meningitis at the stage of clinical suspicion. Then it's very important to emphasize that whenever a viral pathogen is isolated and no bacterial meningitis is diagnosed, then at that point in time, does the clinician need to stop antibiotics and focus on management of viral meningitis only. This is part of the antimicrobial stewardship efforts that need to be taken into consideration when individually treating and managing patients with meningitis, either bacterial or viral. Thank you.
Thank you, Nicola. Thanks for clarifying that. In fact, the another question is, what are other options when when antibiotics don't help in meningitis? And I think that's maybe related, because if it's viral, obviously antibiotics won't help.
Yes, absolutely. You're correct. What we presented primarily is the initial antibiotic regimens that should be given to patients where meningitis is suspected from a clinical standpoint, or based upon initial CSF investigations. However, once again, once the pathogen is isolated, then the antimicrobial treatment regimen, whatever that is, should be revised and optimized accordingly. Again, this also will have an impact on the individual patient, but will also have a tremendous impact when it comes to public health because of the reduced risk of antimicrobial resistance. And on this note, I just wanted to add, following up on some comments that were made both in the chat and by Dr. Joseph regarding the importance of pre-referral antibiotic therapy. Yes, one of the novelties of these guidelines is to consider giving antibiotics before admission to an appropriate healthcare facility if the delay is expected to be likely in terms of referral. But this doesn't correspond to giving away antibiotics to all patients. And one of the critical objectives of developing job aids and revising case definitions is really to define which patients do require pre-referral antibiotic treatment, which patients do meet specific criteria in order to mitigate the overuse or misuse of antibiotics, and once again, mitigate and minimize the risk of antimicrobial resistance. And so, this is also why I mentioned that we're currently developing job aids and clinical tools in this regard. Thank you.
Thank you. We're now almost 20 minutes over time, but one last question perhaps, because I think this is important. Is there any research done this is from Fitsum Debretzian, any research done to diagnose meningitis using cheap, easily available point of care and non-invasive tests to diagnose meningitis?
Can start, and I'm sure that Nicolo can also complement from a more clinical point of view. There's definitely a research done with some of our academic partners in trying to find the markers of meningitis, especially if we're talking meningococcal meningitis in the bloodstream. It is complex because often these bacteria don't always pass the the barrier between our nervous system and the bloodstream. So it's not necessarily always the case that if you have meningitis, you will find it in the bloodstream. So at the same time, especially using new technologies and even, artificial intelligence and trying to identify the markers, even in very low quantities, there is research ongoing. So we are optimistic, but at the moment we're not there in terms of meningococcal meningitis. When we're talking pneumococcus, it is a bit easier because, as I said, there's tests that can identify it in the urine as well. Having said that, I think that the recommended diagnostic procedures are both CSF and blood cultures in any cases you suspect bacterial meningitis. But over to Niccolò to complement with more.
Absolutely. Thank you. Yes, so in terms of point of care tests, unfortunately, at this point in time, we don't have those tests available on a wide scale. And this is something that, together with partners, we're actively working on in terms of developing and researching on point of care tests that can be used for this purpose. So this is something that we need to be aware of. At the same time, again, I wanted to reemphasize Lorenzo's messages and takeaways in that for bacterial pathogen identification and characterization of antimicrobial susceptibility patterns, culture remains the gold standard, and there's no way around this, both CSF and blood culture. In resource-limited settings, this might be particularly challenging, but it would be definitely a priority activity when it comes to improving laboratory investigations and even outbreak confirmation efforts. Over. Thank you very much.
Thank you very much. I wish we had even more time to answer all the questions, and thank you very much to all the participants for the questions and for your participation. But maybe we can try and address them. We can talk with Niccolò and Lorenzo and see if we can answer them in the form of FAQs or something in future, but we will try and address as much of your questions as possible in the times to come. But for today, I think we are well over time. Thank you for your patience, but we should maybe now call it a day for today's webinar. So I'd like to, first of all, thank all the speakers. Particular thanks to Dr. Joseph and Dr. Daniela for being here as the panelists, sparing the time. Thanks very much also to Dr. Lorenzo Pizzoli and Dr. Niccolò Binotto, particularly to Niccolò for organizing this whole event, reaching out to us and enabling us to have this very interesting EPI-WIN webinar. I'd also like to thank people who've worked in the background, my colleague Michael, our collaborators at Project ECHO, Sangamitra, who's here, and others who've helped shape this webinar. But last and not least, to all the participants out there. Some of you I know attend every single EPI-WIN webinar, and we're very grateful to you for your support and your interest. Thank you very much. And as I said, the recording and the presentations will be shared. Please share widely with those who need to know. Many of you have asked about certificates. Currently, because we are really severely resource constrained, certificates are on hold till we find a solution to how we can manage that. But we will find a way eventually, I'm sure. For the June webinars, we have 4 webinars coming up in June. Next week, it will be on MERS-CoV, and we will share the details soon. Thank you once again to everyone, and thank you also for your patience. And I hope you've really enjoyed it and learned this and will be useful. Bye-bye.
Thank
Thank you very much. Thank you very much.